here at MCW. And our goal is to explore free market ideas in healthcare through discourse and debate of important topics in health policy. Tonight our topic is Medicare, and we chose this topic because we think that it's one of the most important issues that physicians are going to be facing in our generation. The specific focus of the debate is defined contribution or premium support, which is one of the solutions out there for Medicare reform. Before we get started, though, we're going to go ahead and do a quick poll, and I know everyone is pretty used to doing this in class. So just to see where everyone's thoughts are on the topic right now. So our question is, so the topic is defined contribution reforms are needed to sustain Medicare. Do you agree or disagree with this statement? So your options are A, yeah, that sounds like a great idea. B, I think Medicare reform is needed, but I'm not sure what kind. C, that sounds like a terrible idea. Or D, I have no idea, I'm just here for the food, and I'll let you know after the debate. So you can use the clickers. We went old school and ditched the ARS system for this.
So basically you just press whatever button you agree with, and it should either self-start, and then I got 53 responses so far, so it's working for some, maybe not for others. But yeah, the letter just corresponds to whatever number of letters on the keypad.
All right. Cool. So this is our response right now before the debate, and we will see what happens after the debate. So I'm going to go ahead and introduce our moderator tonight. Dr. Houston is the Senior Associate Dean for Academic Affairs at the Medical College of Wisconsin. He began his career as a public health service physician and director of a rural health center in Frenchburg, Kentucky. He then moved to Wisconsin and became the residency program director of the Eau Claire Family Medicine Residency Program and associate chair of the Department of Family Medicine at the University of Wisconsin. In 1997, Dr. Houston moved to the Medical University of South Carolina to serve as the chair of the Department of Family Medicine, and he was chair there for the next 15 years. Dr. Houston has had a distinguished career as a researcher and is the author of over 100 original research articles and book chapters. He has participated on national panels on quality of care involving maternity care and hypertension, and we're lucky to have him moderating our event tonight. So here's Dr. Houston.
Thank you, Kate. A very good turnout. Thank you all for coming out here for what I hope will be a very stimulating discussion. I already talked to most of the participants and let them know we want a nice, clean fight tonight. No, not too clean. We don't want it to be really boring. We want it to be a little exciting, have a little bit of the discourse here that will be stimulating to you and hopefully make us all think. You heard about me. I'm going to tell you about them. Yes, I did go to school for 20 years and have 27 years of experience, so I could read off a piece of paper who these folks are. So my job will be to introduce them, and then we'll go through the rules of the debate, just so you know what's coming up. And then you'll also notice on the tables around you are cards, index cards. So we'd like you to write down your questions. And then when we're done with the formal discussion here, we'll have you pass them in. We'll read some of the questions. We might not have time to get through all of them. So as we're going through, please take the time to write those questions as they come to you. If they're answered by others, you can cross them off. But we want to be able to have some good questions so your issues are addressed by our speakers as well. And all the speakers will have a chance to respond to each one of the questions. So let's go through our panelists here first. Our panelist up on the big screen, who is sitting up there in Washington, I believe. Is that right, Bob? Snowy Washington, and is and unable to get here because of the airport being closed, is Bob Moffit. He's a senior fellow, former director of the Heritage Foundation Center for Healthcare Policy Studies, where he specializes in healthcare and entitlement programs with his focus on Medicare. He's also the co-author of Why Obamacare is Wrong for America. Dr. Moffit served as Ronald Reagan's appointment as Assistant Director of Congressional Relations at OPM and then Assistant Secretary for Legislation at Health and Human Services. He's listed in Modern Healthcare Magazine's 2010 list of the 100 most powerful people in healthcare. So welcome, Dr. Moffit. The first gentleman here to my right is Richard Armstrong, and Dr. Armstrong is a board-certified general surgeon. Chief Operating Officer and member of the Executive Board for Doctors for Patient Care. Dr. Armstrong was the owner and president of Superior Surgical PC, and on the board of directors at Grandview Hospital. He's also assistant clinical professor of surgery in the College of Human Medicine at Michigan State University. He's on the board of the Benjamin Rush Society. So please welcome Dr. Armstrong. Sitting to Dr. Armstrong's right is Jonathan Cohn, who's a senior editor at the New Republic, where he covers domestic policy. He's also the author of Sick, the Untold Story of America's Healthcare Crisis and the People Who Pay the Price. He's had a very distinguished career. He's won the Sidney Hillman and Harry Chapin Media Awards, been a finalist for the Robert F. Kennedy Book Award, the New York Public Library's Helen Bernstein Book Award, and the Livingston Award for Young Journalists. Jonathan's presently a member of the National Academy of Social Insurance. He's been a fellow with Demos, a media fellow with the Kaiser Family Foundation, and a Griffith Leadership Fellow at the University of Michigan, where he now lives. So, welcome. And then our final panelist comes all the way from Madison. Kim Hetkso is a physician, an internist, and clinical professor of medicine at UW School of Medicine and Public Health. He's a former trustee with the American Medical Association. Has participated in securing AMA support for the Affordable Care Act in 2009. He's also the former president of the Wisconsin Medical Society, and was one of the 4 physician founders of the Dean Health Plan, and served on the Dean Health Plan board from 1982 to 1994. So our plan for tonight will be... Kim, did you lead that applause yourself and let everybody else join in? That's great. If I fall behind that, just go ahead and clap for yourselves. Somebody has to. So our format for tonight will be each side will have time to present an argument. The other side will then have time to present their argument and a few minutes to respond to it. We'll be starting with Dr. Moffit, who will have 5 minutes to make an argument in support of the proposition. And then Mr. Cohn will go next, and we'll have 8 minutes. 5 minutes for his own argument, plus 3 minutes to respond. We'll come back to Dr. Armstrong, who'll have 8 minutes, and then we'll go over to Kim, who'll have 8 more minutes. And when Dr. Hetkso is done, Dr. Moffit will get the last word with 3 minutes. So everybody ready? All right, Dr. Moffit, you are on the clock. Bob, can you hang on just a minute? We can't hear you, which is not very good when you have a debate.
Hello? Can you hear me?
Yeah.
All right?
Yeah, you're good to go. Go ahead.
Okay, good to go. Thank you very much. Thank you, Mr. Chairman, distinguished colleagues, ladies and gentlemen. President Obama warned 3 years ago, quote, millions of Americans rely on Medicare in their retirement, and millions more will do so in the future. But with an aging population and rising health care costs, we are spending too fast to sustain the program, and if we don't gradually reform the system while protecting current seniors, it won't be there when future retirees need it. We have to reform Medicare in order to strengthen it. Ladies and gentlemen, the President's exactly right, but the best remedy is to inject intense competition into the financing of the program to enforce real competition to control cost and build upon a remedy that it has the best features of Medicare today, and that is a defined contribution program which you see in the Medicare prescription drug program. Let's be clear, Medicare will remain a government program. Medicare would do much better as a defined contribution program, and that would have certain characteristics. It would provide direct payment from the government account to a health plan of a person's choice. Health plans would have to meet government rules and benefit standards of the traditional Medicare program, plus provide protection against the cost of catastrophic illness. No enrollees would be denied coverage or dropped merely because they got sick. Lower income seniors would be eligible for additional financial assistance, just as they are today in the Medicare drug program. And all plans would be required to participate in a risk adjustment system that would guarantee continuity of patient care and at the same time ensure market stability. This approach has demonstrated superior performance in many ways, but let me just mention 3. First, it gives seniors the freedom to choose the coverage that best meets their personal needs. This enables enables them to pick plans that guarantee access to a wide range of comprehensive plans and benefits, including plans with coordinated care and case management, preventive care, and prescription drugs. Second, it would control cost. In its September 2013 report on the defined contribution option, the Congressional Budget Office concluded that this approach would yield savings ranging anywhere from $69 to $275 billion in just 6 years. CBO also concluded that private plans could deliver the same level of benefits at lower prices than traditional Medicare. CBO further concluded that this reform would result in a decline in total national health care spending. Finally, this approach will reduce the fraud and the waste that plagues the traditional Medicare program. With the defined contribution, the government's transactions would be radically reduced to a fixed and transparent annual payment to health plans. These plans would have powerful economic incentives to police their contracts with doctors, hospitals, and other medical professionals to reduce waste or fraud or improper payments, because losses from fraud or waste directly undercut their competitive position, raise their premiums, and undercut their market share in an intensely competitive environment. The performance of the Federal Employees Program, which is a defined contribution program, shows the difference. As economist Walton Francis has noted, in only a relatively handful of instances has the federal government lost substantial sums of money to actual fraud in or by private health plans participating in the federal employee system, or for that matter, Medicare Advantage. Ladies and gentlemen, Medicare spending has temporarily slowed, but it will soon accelerate. Congress has already made benefit promises to current and future retirees amounting to over $36 trillion in benefits that are not paid for. Our options are limited. We can, in fact, raise taxes to cover the cost of Medicare, and those costs are going to rapidly increase in the near future. But this will mean levels of taxation unlike anything Americans have ever seen, reducing the disposable income of younger working families, small businesses, and reducing capital investment. We can also double down on the hundreds of billions of dollars of payment cuts in the Affordable Care Act that are in effect right now, and make it increasingly difficult for doctors and hospitals and clinics to offer high-quality health care that the seniors deserve and expect to get. Or we can inject intense competition into the financing of Medicare to control costs. That approach is not only kinder and gentler to younger working families, the taxpayers who will pay the bulk of the Medicare bills, but it also enhances the solvency of the Medicare program, and it secures high-quality care for our seniors. It is America's best option. Thank you very much.
Thank you, Dr. Moffit. I'm going to invite Jonathan up here to the podium so that Dr. Moffit can hear you better and see you.
Great, he's right here. I can wave to him right there. Hi. Nice to see you. It's surprising that you have more snow than we do up here. That's very odd. Where's the time clock? Over there? Okay, great. Thank you. Ready? Good. Thank you. Thank you for inviting me. Thank you to the Benjamin Rush Society for staging this debate. Thanks for inviting me to one of the very few places in the world that's actually colder than where I live. I appreciate that. And thank you for making an opportunity to talk about such a vitally important topic, Medicare. I always like to start by thinking about when Medicare first became law. Lyndon Johnson was there. If you've ever seen the picture, signing a picture with the bill with Harry Truman. And what did he talk about? He talked about the importance of making sure that seniors could retire in dignity, that they could pay their bills, because prior to that, they couldn't. This was a big problem leading up to the 1960s. Back before Medicare came into existence, only about half of seniors even had health insurance. And those who had health insurance had coverage that frequently didn't pay their bills. Then we got Medicare, and everybody got health insurance. And by the way, the poverty rate among seniors went from 30% where it was then to around 10% today, and Medicare was a big part of that. And I mention all that because we all spend a lot of time talking about Medicare, and what's funny is the salient fact that never gets mentioned, which is that Medicare's primary purpose to protect seniors from financial shock, giving them access to health care, the program has been spectacularly successful as any program in the history of the United States. And you should remember that in this debate, because the resolution we're debating tonight is not, gee, does Medicare need some help? Do we need to improve its finances? It's not, gosh, could it provide for better quality care? It's not, could competition play an important role in that? Because if any of those were the questions, I would say yes. The resolution tonight is we need to go to a premium support system. We need to go to a voucher system, not the most radical change in the history of the program in order to sustain it. And as you think tonight, as you think through this question, I want you to remember that there are 3 tests the affirmative team needs to pass. They need to convince you that Medicare needs saving, that the crisis is so bad that we need to do something radical. They need to convince you that it is impossible to make improvements in the program sufficient to sustain the program within the program as it is now. And, number 3, they need to convince you that their solution, defined contribution, a voucher system, premium support, will get it done. With all due respect to my debating partners, who are incredibly talented and in no doubt good faith, I don't think they can make that case. In fact, I don't even think they can get close. Let's start with saving Medicare. How bad is the financial projections for Medicare? Well, you know what? The Medicare financial projections keep getting better and better and better. You know, in 1999, the Bipartisan Commission on Medicare made a very bold prediction. Medicare was going to go bankrupt in 2010 if we didn't have some kind of radical change. Well, here we are. It's 2014. Medicare's still out there. You know when the projection is for now? 2026. Now, I am not going to lie to you. I'm not going to tell you that the money going into the program will be equal to what it needs to be going out without change. I don't believe that. I actually do think there is a financial shortfall. But it is a moderate financial shortfall. And I actually want to quote Henry Aaron, not the baseball player, mind you, but the economist, one of the best respected economists in the United States, who testified in Congress about this very question. And they asked him, how big a deal is this? And he said, the situation in Medicare does not come close to meeting the characterization that Medicare is in crisis or that Medicare is unsustainable. And the truth is, as Bob Moffit has said, if we wanted to, we could raise taxes, we could run higher deficits, we could sustain the program. I don't think any of those would be great ideas, but it would work. And if the resolution here is that we have to do something radical to save Medicare, well, actually we don't. We can just keep going as we are. Now, the truth is, I don't really believe that we should do nothing. I think Medicare, we should make up that shortfall. The sooner we do it, the better. I also think we should do a better job of helping Medicare to provide for better quality care. Like everyone else, I know that health care in the United States is not as good as it could be. I know we could do a better job. You know what? We're already making those changes. And that's the second part. The idea that we have to radically change Medicare to get more cost savings, it just flies in the face of the evidence. We right now are experiencing the slowest rate of growth in Medicare spending in its history. Partly that's because of structural changes that are taking place in Medicare. Partly that's because of the changes of the Affordable Care Act, which are not just reducing what the program spends, but actually introducing incentives to improve care so that hospitals pay more attention to not giving infections to their patients. So there's more coordination, more focus on prevention. Now, I would like to stand up here and tell you that all of these are going to work, that this is going to be a home run, and every single payment reform in the Affordable Care Act is going to save the program. I don't know that. I'm not going to tell you that. What I can tell you is that some of them are going to work. And we only need some of them to work. And we have time. Right now, Medicare is saving money. It is using the virtues of the program to save money. Why would we want to stop that process now? And keep in mind, Bob Moffit talked about the Federal Employee Health Plan as something that saves money, as an example of how successful it could be. Well, that's a good example. You know what saves money even better than the Federal Employees Health Plan? Medicare. Medicare has held down costs better than private insurance and better than the Federal Employee Plan. This is not even a question if you look at the historical data. Now, what Bob is saying, and this moves us to question number 3, is that somehow going to defined contribution can save even more money. I am here to tell you that is an extremely speculative guess. He cites a recent CBO report. What he does not tell you is that the CBO, when it studied this option, said what would happen, that people who wanted to stay in traditional Medicare, which is what 75% of seniors have right now, would see their costs go up. And what he did not tell you is that that was based on a hypothetical plan, not the actual plans that had been proposed in legislation. And that is really, really important, because the truth is, we all sit up here, we all talk about policy ideas, and we can draw them up on the whiteboard. But take it from someone who has been watching this, who followed the story of the Affordable Care Act from the very beginning, and saw how great those plans looked on paper, and saw what they looked like when they come out at the end of Congress. They never look quite like the same. And if you really want to know what's going to happen, you have to ask yourself, what is the core purpose of the program? And to get the core purpose of a defined contribution program, think of what the word says, defined contribution. I have no doubt that my debating partners want the best of everything. They want to save money for the government. They want to save money for the country. They want good access to health care for everybody. We all want that. But what matters is your priorities. And their number one priority starts with a promise to the taxpayers and a promise to the government. We will not spend more than X. That is what defined contribution is. It is saying we are going to set a voucher level. That is what we are going to spend. And whatever else happens, that's our most important priority. And when you do that, you get plans like the Paul Ryan plan, the old Paul Ryan plan, which Bob Moffit endorsed at the time and everybody said would be great, that left seniors owing thousands of dollars a year in out-of-pocket expenses. The median income of a senior citizen today, $23,000. Think about that for a second. Now, what was the promise that Lyndon Johnson made? His promise was to seniors. He said, no matter what, we will get you the health care. We will protect you. We will make sure whatever we have to do, we will guarantee you that access. That is a sacred promise. And if we are asking the question, what do we need to do to sustain Medicare? I think the basic premise has to be, we have to start by actually sustaining Medicare. You may think a defined contribution plan sounds dandy. You may think it's a good idea. I may think it's a good idea. But here's what it's not. It's not Medicare. It is a fundamental change in the program. It is replacing Medicare with something else, something we haven't seen at a time when Medicare seems to be taking care of its own problems. And if for that reason and no other reason, you cannot support this resolution. Thank you.
Dr. Armstrong, I think it's all yours.
Thank you. Hi, Bob. Sorry you're not here. Well, thank you and good evening. Thank you to the Benjamin Rush Institute and Kate Nix and Beth Haynes for organizing this and inviting me to participate. You know, there are two components to the relationship between physicians and patients, and I like to keep this really basic so everybody gets it. The professional duty to be the patient's individual advocate for healthcare, and there is an economic component. So people don't like to talk about that, but there is an economic component. The doctor provides a valuable service, and then the doctor and the patient agree upon payment. The source of our problems for decades has been that the economic component of this relationship has been opaque for both parties, the doctor and the patient. We all know this is true. We live it every day in our practices. In the majority of economic interactions with patients, there is an unseen third party paying the bill. Most often, doctors are unaware of the charges, as are the patients. Is it any wonder that we've lost control economically? Any wonder at all? In spite of stiff opposition, you mentioned President Johnson, in spite of stiff opposition from members of his own party due to the economic concerns, and opposition from the American Medical Association, the political stars aligned in 1965, and President Lyndon Johnson was able to pass Medicare, which was a fiscally unsustainable program from the beginning. He took pains to hide that from members of his own party at the time. Does any of that sound familiar? As you have heard, transitioning Medicare to a defined contribution premium support program is not a radical or new proposal. In fact, premium support was favored by the majority of the members of the National Bipartisan Commission on the Future of Medicare in 1999 under the Clinton administration. Premium support was also recommended by the Simpson-Bowles Commission and has been recommended by the American Medical Association Council on Medical Service in their report from November of 2012. A National Bipartisan Commission in 1999 estimated that adoption of premium support would reduce Medicare spending growth by 12% over the next decade, but they lacked the supermajority in their committee by one vote to pass this on to the President and Congress. Premium support proposals do not end Medicare as we know it. That's already occurring. The changes that have been put in place with the Affordable Care Act are ending Medicare as all of us have known it. It does not throw a vulnerable population of seniors into the uncertain ravages of a free market. What it does do is recognize reality, that demand for medical services exceeds supply, and the available financial resources from taxpayers to support it. This has been outlined well in Bob's opening remarks. All premium support proposals utilize the power of consumer choice and market competition to hold down spending and promote innovation in both insurance products and medical delivery systems. Of course, Mr. Cohn has raised some objections, and some of those objections are reasonable. However, one of the things that we need to recognize is that today, 10,000 retirees are going on Medicare every day, and the pool of people in the workforce that are paying for those retirees is diminishing, while the pool of people that are beneficiaries is increasing. And in fact, in their lifetimes, people that pay into Medicare on average pay $1 in and get $3 out. So the pool of people that are paying in is decreasing, the beneficiaries are increasing, people that are getting benefits are getting $3 for every dollar that they paid in. And I might tell you this, it's not real insurance, because that money that they paid in is not in some magic pot somewhere that they can draw from. It's money that's being paid in by current people who are working, not the money that they put in years ago. So make sure that you understand that. The other thing that it's important to know is that the ACA does diminish Medicare, but it diminishes by reducing payments to providers and hospitals. That's what the iPad is all about, and that's what the reductions are all about in some of these systems. The other thing that's very important to know is that $500 billion at least from the Medicare program over the next decade is slated to be moved to support the premium supports of people in the ACA, the people that are having trouble getting insurance today. The other thing that's supposed to control spending in healthcare are new payment models in the ACA. One of them is a accountable care organization, and I might mention this to you briefly because you might have heard of them. Say you take a pot of money and give it to a bunch of doctors that are going to take care of Medicare patients, and you say, here, this is this fixed pot. And you say to them, we're going to have you take care of these people, and if you do a really good job of taking care of these people, you can keep some of this money and take it home with you. So what do doctors do? They try to deny care to their patients, because if you do less MRIs, less CT scans, less expensive care, you get to take home some of the money. Does that sound like an ethical program? I don't think so. That's my opinion, but that's the opinion of a lot of other doctors. It's been said that premium support would destroy Medicare. But as I mentioned, current changes in Medicare are already contained in the ACA, are on track to change Medicare as we know it. I should note that all premium support proposals contain a provision to allow traditional Medicare fee-for-service to be readily available in the Medicare program, in the premium support plans. Any senior who chose to remain in traditional Medicare would be free to do so. Also, all beneficiaries would have the option to choose better plans. My assertion is that if Mr. Cohn and his partner believe that Medicare fee-for-service is good, then why not put it to the market test against all the other plans? If people want it, they can have it. Premium support will not privatize Medicare. This charge has little meaning, as the majority of medical delivery systems currently participating in Medicare are private. Also, 9 out of 10 current enrollees in traditional Medicare have private supplemental insurance plans, which they choose on their own from multiple Medigap supplements. And the other thing that should be noted is that the majority of Medicare is administered through private contractors, Blue Cross and Blue Shield, and other companies. Premium support has been mentioned to increase premiums, but this is not necessarily true. It depends on the design of the program, as outlined in the CV overview from September of 2013. The average bid option in that program would lower premium payments by 6%, while the second lowest bid option could raise them by as much as 11%. But if you're going to ask people to reduce the cost in a government program, you're going to have to ask people to pay a little bit more money out of their pocket. However, the premium support programs protect people at the lowest end, and the people at the highest end end up having to pay more. We think this is fair. So enrollees will be free to purchase plans above or below the government specified support payment. And if they chose a less expensive plan, they would get money back. If they chose a more expensive plan, they would have to pay more. And thank you very much.
Our last speaker, Dr. Hetkso. Okay, thanks.
To see if I can position myself correctly. That's good. Thank you very kindly. I'm in a unique position here because I have also treated Medicare patients for 49 years. And for the last 5 years, I'm a Medicare recipient because I'm covered by Medicare. I also teach at the University of Wisconsin over Madison. And I've also been very aware of the fact that Medicare is very well accepted by the senior population in the United States. And most seniors don't want it tinkered with too much. In essence, they're saying, and this is what the Medicare trustees say, the system ain't broke. It's fiscally sound, at least for the next 15, 20 years. Why should we go ahead and do radical surgery when we can go ahead and make some changes on the edge to deal with it? We've made changes on the edge in the past that have helped it. You can increase the age of eligibility by 6 months a year, which has been done in the past, and it greatly changes the actuarial pictures for the future. You know, they say that an actuary is a CPA with a personality, but the actuaries have constantly looked at this, and they're the non-partisan AMH or trustees have kept a close eye on it. It is a fiscally solvent program. It does not need radical surgery. We don't need to go ahead and just start all of a sudden to give seniors, especially to those seniors who are in very vulnerable situations, only a partial premium to go ahead and pay for their health care. That's inappropriate and a big step backward. And most seniors are in opposition to that. Medicare has been a very successful program in terms of acceptance by the senior population in the United States. It also has been relatively cost-effective and cost-efficient. The State of Wisconsin Insurance Commissioner maintains a number of bits of data in terms of something called the medical expense ratio. The medical expense ratio is the percentage of premium dollar that actually goes to paying for health care. And what percentage does not go to pay for health care? We were shocked when I was on some national committees about 4 years ago to realize and find out that there were a number of insurance plans, not in Wisconsin, but in states like California, Alabama, Louisiana, Arkansas, that were only paying out 63 cents on the dollar. So if you bought a health care policy from them, a premium of $1, you only got 63 cents back. The rest of it went to excesses. And what are some of those excesses? We can touch on that. But this is the problem. The medical expense ratios were so atrocious in those states. And what was happening? In Wisconsin, we've always been in the high 80s, low 90s in terms of medical expense ratio. However, the benchmark has been Medicare, which has consistently been in the medical expense ratio of 92 to 94 cents on the dollar, actually going to provide care out of the premium as opposed to even a number of the more private companies. And I set up a private company here in Madison called the Health Plan, and I helped run it for a number of years. And we went from 0 to 150,000 enrolls. And we had $25 million excess reserve by the time I stepped off that board, and it's still doing exceedingly well. What I'm trying to come back to is that Medicare has been a very cost-effective and cost-efficient program. What we have, if we don't have Medicare, and we don't have a healthcare system in this country with various stopgaps, we have chaos. The president of the Cleveland Clinic recently testified before Congress that if we go ahead and we take away the Affordable Care Act, we take away and dismantle Medicare, we dismantle medical assistance, Medicaid, we end up with a small cottage industry. The patient doesn't have an ability to decide what is the best care, what is the most cost-effective care. Most people are at the liberty or at the mercy of the emergency room and the emergency room physician to decide what are the appropriate amounts of care, how much care, and where they should get their care. And so the patient is really not part of the economic system, even when they have some skin in the process. So I just bring that up and want you to keep that in mind. You know, there was a very, very nice article in Time magazine on March 6th this past year. The entire issue of Time magazine was focused on a bitter pill, the cost of health care in the United States and what is driving it. And Stephen Brill did a brilliant job, and you can go ahead and find that on the internet, and I wish you would, of looking at what are driving the costs and the high costs of health care in the United States. And he is quick to point out, it's not the doctors, and it's not the nurses. It is the hospitals and the hospital administrators who, by the hundreds, are getting paid across this country salaries in excess of $1 million. We have salaries in Wisconsin, the average salary of a hospital administrator of a not-for-profit hospital exceeding $1 million. Incredible. Incredible. We have insurance companies, and some of the excesses in insurance companies are absolutely astonishing. We have the largest health insurer in the country, which is United Healthcare out of Edina, Minnesota. And the CEO of United Healthcare in 2007, public article, took home a salary of $2.1 billion with a B. Now, he was found to have priced some of his stock earnings inappropriately or impossibly low when he got them and high when he sold them. And so he had the Securities and Exchange Commission made sure that he had to give back $485 million, and he had to make do that year, and I don't know how he did with the salary then at $1.6 billion. But it shows the excesses in this system, and we've got to do something about it. Big pharmacy, durable medical equipment, all of these things, hospitals themselves. I talk about the invasion of the cranes. I give talks around this country. I can't go into a city where there's not major hospital construction. Look at here. Look at Madison. Look at everywhere you travel to. Has the population of Milwaukee increased that much? Has the population of Madison increased that much? No. A lot of this has been on the back of hospital reimbursement under Medicare. Some of this is going to have to be cut back, and we're going to have to become a lot more cost-effective and cost-efficient. But I believe we do not need to throw out the baby with the bathwater, and let's not go ahead and do radical surgery on something that's not truly broken. Let's work on improving Medicare so it'll be around for another 49 years. Thank you.
We've come to our last rebuttal. I'm going to try to kill a few seconds here while Kyle tries to get Bob up here on the overhead microphone. I remind you that there are cards on your table. If you haven't grabbed one yet to write down a question, something you want the group to comment on, please do so now. After Dr. Moffit's finished, I have a couple of questions which will hopefully entertain you while you're planning yours, and we'll sort through them. interaction, we can actually hear you through the speakers. So you have 3 minutes to respond to what you hear.
Ladies and gentlemen, the way we analysis and suggested worked out is to think of impossible things before breakfast. Imagine for example, a North Korean defense attorney. I mean, all this is asking us to believe some impossible things. The white meat tells us that we should exercise our brains by trying to think 6 impossible things before breakfast. I use the example of North Korean defense attorney. The other idea, sustainability of Medicare without any kind of significant change. The fact is, we cannot simply, the other idea, sustainability of Medicare without any kind of significant change. The fact is, we cannot simply cut Medicare payments or tighten price controls on senior citizen services without hurting. Under the Affordable Care Act, Medicare is going to see a progressively larger number of Medicare providers operating in the range primarily because Medicare is taking cuts. The Medicare actuary says that by 2019, 15% of Medicare providers were providers. Senator Rob White, Democrat, a long-time champion of hard reform, has put it deeply. Absent a bipartisan effort to fix Medicare and protect the guarantee, if nothing is done, what the years ahead in store is that seniors and healthcare providers will be getting a steady diet of cost-shifting, arbitrary cuts until the Medicare guarantee is kaput. The Affordable Care Act provides for some delivery reforms, and I don't discount the potential of those delivery reforms. But we are faced with a long-term financial debt of $36 trillion. Defined contribution financing will bring fiscal discipline into the program, and it will expand options and improve benefits for senior citizens. Jonathan Cohn said defined contribution is radical, but it's not. It builds upon the provision of comprehensive benefits in Medicare Part C today and Medicare Part C that already cover a vast majority of senior citizens. That's not a radical approach. That's basically an expansion of something that we know that works. Considering what the alternative for seniors having the choice to be enrolled in a fully integrated health insurance plan, operating in a highly competitive environment, price transparency is the best hope for a future of high-quality care and affordable care and secure care for the vast majority for all of our seniors. Thank you.
Thank you to all our speakers. Now we're up to our question and answer session. And my first question here is, let me see if I can read this. I wrote it, so it's the first part of it. We've talked about Medicare here as if it's a monolithic program. But like hepatitis, it has multiple as A, B, C, and D. It does make you yellow and sick to your stomach like hepatitis does. But a couple of these programs, B and D, are already premium supported. So realizing that, I'm going to ask each group here to maybe give me 30 to 60 seconds on how do you use the fact that 2 parts of Medicare are already premium supported to support this proposition or to say this proposition will work. So we're going to start with Bob.
No, I think we have a increased experience of Medicare Part D, Medicare Part C. Earlier on, Jonathan made the point that Medicare payments have been slowing because of slowdown in Medicare Medicare for time. Well, the Congressional Budget Office just recently did a report and pointed out that compared to 2012, 2013 projections are much lower. And what they found was that Part D spending, which is the premium support program, is the largest contributor to CBO's downward revision in its forecast. It accounts for about 67% of the total projected savings. Now, such a strong performance holds promise for substantial savings if we unleash that kind of market competition throughout the entire Medicare program. Medicare Part D works. It's not perfect. It's got to be improved. The payment system is flawed. Medicare Part D has beaten all expectations in providing high-quality care, the broadest range of prescription drug benefits, at costs that are lower than anyone could have ever imagined.
Kim, do you want to speak next? We'll go in reverse order. Okay, Jonathan's going to speak next.
So quick, on Part D, and I think Bob knows this, I think everybody who studied recent economics knows, Part D did come in way below projections. The reason it's commonly understood, and I think universally agreed upon, is that there's been a slowdown in the drug pipeline. Every drug insurance program is much lower than expected because drug costs are going down. That is not because of the structure of Part D. That's because we're not inventing a lot of new drugs right now. Drug costs are coming down. But I do want to say that you are asking, if I think I understand your question correctly, don't we have premium support aid version? What we have is we have competition. We have a Medicare Advantage program within Medicare where people can opt into private plans. You know what? I think that's great. I am all for that. And again, if the resolution here was, can't we use competition to kind of improve the finances of Medicare? I said, yeah, that's great. Let's set up a competition kind of like the one we have now, ratchet it up a little bit. But that's not what this plan is. That's not what defined contribution is. That is a defined contribution is an entirely different way of doing it. And it starts, like I said, but I guarantee you, we're going to pay this much. And that's the limiting factor. That's the key distinction. And that is the lead that I think you can't just justify.
There's another factor, too, if I might add, for a second, and that's that a lot of the drugs have gone generic that were branded and they've gone generic in the past year. Makes a big difference in the cost. It made a big difference in my cost of drugs for myself.
Okay. I think that, is this on? I think that we could disagree about why drug costs have come down in Part D. Part D has come in lower than projected. We think, and I think because of the premium support and the competition in the program. We also think that seniors are able to choose, as you mentioned, in Medicare Part C, in the Medicare Advantage program, along a group of plans that allow them to get better benefits and choose what they want, which is really what we're talking about with a little bit of a tweak in the way the premium support would work, is it combines A and B into one program, and then also adds catastrophic coverage to that, which isn't in the Medicare program now. People have to buy Medicare coverage for that, and then shift the cost so that the people who need it most gets tested, so that the people who need it most get it and get most of the benefit, and then people that don't need as much of it don't get the benefit. That is fair. And then Dr. Hetkso mentioned that a gradual increase in the age, which was recommended in 1999 by the panel on the bipartisan panel on Medicare support, could help us move toward fiscal solvency. And I just disagree that it's a solvent program. It's not.
Second.
Can you guys speak a little bit more in the microphones?
Sure.
Thank you.
Is that better?
Second.
Sorry about that.
An asked person discussion is the 1996 Medicare Reform Act. Provision was put in the Sustainable Growth Allowance, SGR, Sustainable Growth Rate. For the students in the audience, basically what Medicare said was, for physicians, you can order, we make money two ways. We get paid, and we get paid more if we order more. So if we order more and the price goes up, the next year what we get paid goes down. So there's one budget. In the first year, there's about 3% overpaying or overexpense. And subsequent years, there's been ongoing overexpenses. The cost to the payment back to physicians has never been up. It's up to, Kim probably knows now, 30-something percent.
Well, it's gone down a bit, but the SGR is a formula that's been used. In essence, what's happened is that physician reimbursement under Part B Medicare, which is the part that pays physicians, has in essence been frozen for the last 10 years, 12 years. And the big factor that's been used to freeze it has been something, this false equation called the SGR. Congress, both parties, have to take absolute fault for not having gone to the woodshed and done something about this. Both parties in the White House need to take responsibility for not having done something about this. It started being implemented in 2001, and it's still out there. It may be near a solution in the very near future, but I've heard that promise too many times over the years.
My question out here, though, for the panel, and for Bob, is we put that in place as a budget that we would live under. And we've never lived under that budget. So do we have the stomach to enforce a plan such as this?
No. The answer is no. We have acted that in 1997 and 2003. Every single time we had budget tax or physician payment, Congress has intervened to prevent the cuts to physician payment from taking effect. What's strange about this is that the President of the United States incorporated a budget tax in Medicare. He wants to tighten up even further than that. What he wants to do is he decided that he's going to propose a cap on Medicare of GDP, growth in the economy, plus 0.5%. Now, it's true that Congressman Ryan and others in Congress have agreed to the idea of a budget cap. But if you don't like the budget cap and premium support, you can't like it if the Obama administration attended. You can't like it in the Affordable Care Act. And if you think that a premium support would somehow or other create greater difficulties for beneficiaries than budget cap in the Obama proposal, then let me call expert witness. Keith Clark, who's a Democrat of California, was interviewed by the New York Times on the Independent Bank Advisory Board that John thinks is a terrific idea. And let me tell you what Keith Clark said. In theory, at least you could set a value of premium support in an adequate level. But in an effort to limit the growth of Medicare spending, the board, including the cap, is likely to set an adequate payment rate for health care providers, which would increase patient care. End quote. We invest other than that. If you have a premium support, your payment is based on real conditions in the market, as the market payment change. And that means most seniors will get a petition where they don't really have to pay higher than they won't pay. Many of them could be able to buy a plan that is premium-free. Right now, 90% of seniors Medicare Medicaid pay no extra premium, other than the market premium they pay today.
Jonathan would like to respond to that.
Yeah.
And then we'll go to questions from the audience.
Well, that sounds good. That sounds good. The SGR story, I think there's not a person in the world who studies health policy who thinks the SGR was a good piece of law. And I don't, for a second, want to try to defend it. It was a bad decision, a bad law they passed. At some point, they're going to have to fix it. That's what happens. But the question was, given the experience with this doc change that we get every year, why should we believe that we'll have the stomach to keep the cuts that are already in Medicare? Why should we have faith that they'll stay over in the future? And that's an important question, right? Because I said, the fiscal picture looks better, and I'm assuming a lot of those cuts will stay in. So two things. First of all, actually, the actuaries, the CBO, and all that, actually assumed that some of them wouldn't stay in. So their projections are kind of a worst-case scenario. So actually, they're assuming Congress will lose its spine and will kind of pull back. But the second thing is that story about the SGR. There's a detail that never gets told in that story. And here it is. The SGR was one of the series of cuts to Medicare that were passed in the late 90s. So a much larger series of cuts. You know what happened with those? They stuck. They're one of the reasons that we now have a much better outlook for Medicare. But the SGR was a particularly poorly designed one. And that's why we keep putting it off. But all the other cuts, they have stuck in. And by the way, everyone keeps sort of saying, oh, these cuts, they're not going to. Well, one of the reasons the Affordable Care Act is kind of hard to implement is that they're actually doing what they said, and they're making painful cuts. And they're hard. And you know what? They're doing it. So this idea that we don't have the stomach for cuts, I think, it flies in the face of the evidence.
I'm going to turn to the questions from the audience now. Many of these questions are directed towards one side of the argument or the other. In the interest of time, so we can get through as many questions as we can, I'll ask one participant from each side. So I'll ask Dick to address this one. Unless you say, well, that's a better one for Bob. See, I heard that seniors also can choose to purchase private plans to supplement Medicare. Will DCR lead to poorer seniors receiving progressively less valuable care until it's no longer sufficient?
The answer, the simple answer is no. Right now, as you know, in Medicare fee-for-service, which is kind of Part A and Part B together, it doesn't cover everything. And so seniors have to, if they don't want to have a big out-of-pocket expense, they have to buy a Medigap plan. And you probably all heard about that. 9 out of 10 seniors that are currently in the traditional Medicare program buy a Medigap plan, and they choose from many, many plans. And in general, and studies have borne this out, they're happy with those choices. But in the premium support program, Medicare Part A and Part B would be melded, and there would be catastrophic coverage, making these choices of these Medigap plans not really necessary anymore. But they would be able to choose among a group of plans through a federal exchange that was tightly regulated, and people that were at the lowest end of the income stream would get the most support. So it's really a fallacy to think that these people would somehow be shortchanged in the long run. It would not be.
The next question I will ask him to address.
Sure.
If Medicare recipients, current and future, will take more out than they've paid in, how is this possibly a fiscally sound program?
Well, I think you're drinking Kool-Aid here. This program has been sustained. There is no trust account, really, in terms of putting money in the bank and investing it for the future. But certainly it's been a pay-as-you-go program, and that's what they're looking at when they do the actuarial pictures of where everything looks. We start hearing some of these projections going out for 30 years, 50 years. Who knows what healthcare is going to be like 50 years or 75 years from now? And I think it's hard enough for us to know what it's going to be 5 years from now and the changes that have occurred. And anything beyond that is pure guessing. Pure guessing, because you really don't know. And that's the real problem with the whole issue. There's so many variables and there's so many differential things going on that it's really hard to take a look. But right now it's been a pay-as-you-go plan.
Bob, are you with us?
Yeah, I'm with you.
Good. I have a question for you then.
Okay.
Overhead is increasing for medical practices. Medical education debt is past $150,000 on average per new doctor, and Medicare reimbursement is declining. How will Medicare reverse this trend, and how will premium support reverse this trend?
I think the big way forward would reverse the trend is that we pay doctors a market price, not an arbitrarily low price. What you have now is a situation where every physician in the country is paid on a fee basis, which may have nothing whatsoever to do with the actual physician's supply and demand. With Medicare premium support, or the payment plan based on a real medical competition among different plans, you have a real market price. My concern of the current is that we are looking at progressively lower reimbursements as time goes on, and more physicians are going to find it almost impossible to continue to practice medicine as they have in the past. Moreover, it's becoming more difficult for doctors to actually shift costs in the private sector as they used to, primarily because of the Affordable Care Act. So I see a great access coming, especially with the baby boomers. We already have a connected shortage of physicians of about 120,000, and we're going to add between 50 million now we're going to go to $8 billion in the next 20 years. That's a real problem. We have a lower supply and a bigger demand, and we have a pricing mechanism that is absolutely has absolutely nothing to do with reality.
Can I make a comment about that? One thing that Bob didn't add about the premium support program and doctors being able to decide economics with patients is all major premium support programs have a provision in it for private contracting, which is the Benjamin Rush component of this, because it's free market. And that means, and we can discuss that means that doctors and patients can decide on their own, outside of Medicare, how much they're going to charge each other. So if you can't keep your office open because your overhead's too high, you can raise your prices in private contracting.
Well, this question feeds right into your answer there in our discussion. So I'll ask you, Jonathan, to talk a little bit about this, and she had a stand up. I think it plays off that because currently Medicare plays a large role in controlling costs, not only for enrollees, but for all participants in the U.S. health system. If we change Medicare to a premium support program, does the government lose leverage in the ability to control all costs?
Yeah, that's a great question, and the answer is yes. CBO, in its estimates, if you read the analysis, or any recent analysis, or you look at the very important paper by David Cutler and Michael Chernew on savings from possible savings from premium support, they all say, and I meant to mention this, that private plans in Medicare, one reason, to the extent they think they might be successful, is that they are going to drag on Medicare on a bicycle racer. That because they have Medicare kind of pushing prices down, and the private plans keep off that. I have a question, actually. Maybe it's going to answer it, but this always, I never understand this. So there's a lot of concern that Medicare is rationing down payments for doctors and people won't be able to get to see them. Now, we have survey data on this, and actually, by far, it's not even close. If you have Medicare, it's much easier to see a doctor than if you have private insurance. The percentage of doctors who see Medicare patients is over 90%, and that is higher than private insurance, considerably higher. But he doesn't say, let's say that my debating partner here is right, in that the public plan Medicare is going to ratchet down the payment, make it hard, and then they say, but private plans through competition are going to lower costs. How do you think those private plans are going to do it? I'll tell you how they're going to do it. They're going to pay the doctors less. And if you don't believe me, go look at what's happening in the federal exchanges and the Affordable Care Act. That's how private plans lower prices. They bargain with doctors. They narrow networks. Now, I actually don't have such a problem with that in principle if you do it right. But this idea that somehow, Medicare is going to cut off access to doctors and private plans, forget the statistics, forget the numbers. Y'all ever use private insurance? How easy is it to get into a doctor? How many doctors complain about dealing with private insurance? I don't get this idea of how it is that going to premium support is somehow supposed to be a physician's relief, unless physicians get to charge a lot more, which, a good deal if you're a physician. I worry about the senior at $23,000. It's got me out-of-pocket expenses trying to bargain for that. Doesn't have the money, and then where are we?
Now remember that premium support is a euphemism and another word for a voucher that only pays a fixed amount towards your health care premiums. And if it's 50 cents that it'll pay on the premiums on the dollar of the companies that are available in your locale, too bad, that's it. And that's our concern, is that you'd be stuck, or the seniors most at risk will be stuck for the rest of that premium dollar. And they're not going to be able to afford it. The people who are getting $24,000, it is a euphemism for only paying a certain amount. I've got somebody who's raising a lot of questions on my side.
You've got your partners up there, so sorry.
Yes, he's signaling back and forth.
You should just set out that red dot is in the face of there.
Yes. But that's the concern. Is what happens is poor seniors caught in between. Now that's a big problem we've had in this country too. In coming to this point, whether we talk about Medicare or we talk about those under age 65, we have right now 45 to 50 million people not covered by health insurance in the United States. What's our solution?
Well, I want to clarify something. I think voucher is used by my opponents in a pejorative way.
I hope we're colleagues.
Well, your colleagues, but not your opponents. The voucher, the term voucher, especially if you read your literature, it's used in a pejorative way. And what it tries to say to people is that the government is just going to give a senior a certain amount of money and then just throw you out there in this rapacious, awful market where it's really difficult to buy health insurance. That is just totally false. Premium support programs. The patient picks a plan. The plan is approved stringently by government, just like in the Affordable Care Act right now. And the government pays the company directly the premium support payment. It's not a voucher system. It's not some money that's handed to somebody that's a poor senior that is, 85 years old and can't figure out what to do. When they pick their plan, and they've done this in Medicare plans, and they're happy with it, their money goes directly to the plan. It's not a voucher. That's
This is actually going to be our last question because we're almost at our appointed time for our revote. So you get the last opportunity again to make a comment on this question.
What is the question?
I'm sure hoping you remember. Medicare plays a large role in controlling costs, not only for enrollees, but also sets the bar for the entire healthcare system. If we change Medicare to a premium support program, does the government lose leverage in ability to control costs?
Oh, the answer is yes. The government would, because the government would not have the kind of control over prices that it has in Medicare today, which is causing this enormous cost shifting in the private sector. Right now, Sullivan says that we will pay about $88 billion Medicare and Medicaid cost shifting because of Medicare growth control. Under the current system, we're looking at the reimbursement for doctors going down. A lot of private sector companies follow that. But as we pointed out earlier, with sustainable growth rate, none of this is really sustainable over time. Congress routinely revealed the limitations it poses in the Medicare program. One of the things that the Congressional Budget Book was found in the 2013 report was the intensity competition would bring total national health care spending down as a result of the intensity of competition that could cause lower plan premiums for both seniors and also plans themselves to offer benefits for competitors.
Thank you. I have a number of other questions. I've read through these. I'm very impressed with the thought put into these, the background provided. So I know you're very attuned to this, and extremely good questions here. Unfortunately, we won't have time to get through them. I want to take a moment, though, to thank all our panelists now before we vote. Dr. Moffit? And then Dr. Cohn? Please arm yourselves with your clickers, because we're going to again ask you to vote A, B, C, and D, and we'll compare these to the end.
All right, the questions are the same as they were before. So defined contributions reforms are needed to sustain Medicare. How do you feel about that statement?
Is this Chicago? Can you vote early and often? That's why they're moving around.
All right, so we are going to go ahead and put in the answers. So we started with 54 people last time, and now there's 58. So who's voting twice? This is Wisconsin, guys, not Chicago. All right. All right. So So this is our first poll. We had 9% of people said that sounds like a great idea, and 69% said, I think Medicare reform is needed, but I'm not sure what kind. 2% said that's a terrible idea, and 20 of you weren't really sure. And now we've had some movement. So now 34% think that premium support sounds like a good idea. 43% said that they are not, or they think Medicare reform needs change, but they're not sure what kind. 22% said that sounds like a terrible idea. And 0% of you said, I have no idea. So to me, that's a success. So thank you all for coming. Thank you so much to Dr. Houston for being our moderator tonight.